Welcome to the patient care orientation section that focuses on the detection of early warning signs and sepsis. My name is Nova Francis, and I'm Baptist Hospital's Clinical Intervention APRN for sepsis. I'm a board-certified emergency nurse as well as nurse practitioner, and I also moonlight with the hospitalist group, so you might see me out and about on the units. Be sure to grab one of my cards so you can reach out to me as a resource as you transition to practice here at Baptist. If you're watching this video, it's because I've taken a PDO and I'm on the beach somewhere, otherwise double booked. In that instance, just know that I would much rather be here with you in person to cover this very important topic. Over the next 20 or 30 minutes, our objectives will be to review tools that can help you reduce your patient's risk of mortality while under your care. So let's get started. Sepsis is the body's overwhelming and life-threatening response to an infection, which can lead to tissue damage, organ failure, and death. While sepsis is an equal opportunity killer impacting the sick, the well, and people of all ages, some groups are more likely to be affected. These include very young children, older adults, those with a weakened immune system, racial and ethnic minorities, and lower-income individuals and families. Sepsis affects an estimated 39 million people worldwide each year and contributes to 20% of all deaths globally. However, when you poll Americans, only 65% say that they know the word sepsis. When compared to stroke, around 72% of Americans can identify stroke symptoms, yet only 12% can identify the most common sepsis symptoms. More than 1.7 million people in the United States are diagnosed with sepsis each year. That's 1 every 20 seconds, and the incidence is rising. It is estimated that each year, more than 80,000 sepsis survivors are discharged to hospice after a sepsis hospitalization. Each year, more than 75,000 children in the United States develop severe sepsis, and 6,800 of those children die. Sepsis causes at least 261,000 maternal deaths every year worldwide and is driving increasing and pregnancy-related deaths in the United States. Sepsis survivors have a shorter life expectancy and are more likely to suffer from an impaired quality of life and often experience worsening cognitive and physical function. Sepsis is the #1 cost of hospitalizations in the United States. Costs for acute sepsis hospitalization and skilled nursing are estimated to be $62 billion annually. This is only a portion of all sepsis-related costs, since there are substantial additional costs after discharge for many. 1 out of 3 sepsis survivors are hospitalized within 3 months of initial sepsis episode. In your packet, you'll find a sepsis fact sheet. Please review the ways that you can help prevent infections and illnesses that can lead to sepsis. Something as simple as encouraging your patient to turn, cough, deep breathe, perform good oral hygiene, have good bathroom hygiene, and great skin care could make or break a hospitalization turning into a sepsis episode. Take the time to educate your patients and families on ways they can prevent sepsis once they are discharged from the hospital. So how do we screen patients for sepsis? In the emergency department, we screen every patient during triage on arrival. On the inpatient units, we do sepsis screening on admission, every shift, and PRN. The reason why we screen so often is because signs and symptoms of sepsis can wax and wane. Sometimes it's not obvious on admission that there's an infection brewing and the immune system is about to go haywire. It's even possible for sepsis to be present on admission, and 2 days later, patient symptoms improve and then go into what we call resepsis, where the immune system has a secondary inflammatory response. It's important to realize sepsis can occur in patients with no comorbidities, no history of infection, and otherwise healthy. Sepsis screening is fairly easy. Once you get out a report, scan your patient list and ask yourself who's here for an infection or potential infection. The next step would be to review the vital signs and the lab work. If they are showing signs of systemic inflammatory response syndrome or having any signs of organ dysfunction, we need to act fast. On your unit, you will find the potential sepsis screening tool form, which can help you to screen patients for sepsis more efficiently. If you have identified a patient with sepsis or potential septic shock, You must contact the provider and make them aware. The next steps would be to implement the sepsis bundle. We have a sepsis order set in Allscripts. The bundle includes a stat lactic acid, stat blood cultures ×2, and ensure a broad spectrum antibiotic is ordered to be administered after the blood cultures are drawn. For those who work in the emergency department and will be drawing their own blood cultures, it is very important to make sure that the blood cultures are drawn perfectly and timely before starting the antibiotics. It's also important to be mindful that some phlebotomy techniques could cause falsely elevated lactates. If the patient is hard stick, please avoid using multiple tourniquets. Please avoid leaving the tourniquet on for too long. Be mindful for how long the specimen has been collected and make sure it gets on ice and sent to the lab promptly. On the other side of the sepsis screening tool, you will find the sepsis bundle completion form. This is a timeline used to abstract very important information on the care that we deliver to sepsis patients. At the top, you'll see a line for time 0. This is the time that the positive sepsis screening was called to the provider. The first 3 hours involve getting lab work and the antibiotics started. You must ensure that a sepsis lactate is ordered so that the result can be called to you if greater than 2. If your lactate is greater than 2, then you must repeat the lactate within 6 hours, preferably after you've given some fluids. For those sepsis patients that have low blood pressure or a sepsis lactate greater than 4, they meet clinical criteria for septic shock. It is standard of care to infuse normal saline or lactated ringers in the amount of 30 mL per kg. After the infusion is complete, continue to check vital signs, ensuring that you've documented whether there's been an improvement or no improvement. If the patient is a non-responder to the fluid bolus, the next step is to obtain an order for vasopressors. Procalcitonin is a marker that we track and trend on admission and every day to rule out or rule in a bacterial infection. This has been particularly important with viral sepsis due to COVID. Negative procalcitonins allow us to decelerate and discontinue antibiotics to prevent any potential multi-drug resistant opportunistic pathogens. Patients admitted to the hospital are at risk for deterioration for many reasons. Whether it's sepsis, progression of an existing disease process, expected end-of-life response, or even human error, it's important to pay attention to the signs. At the beginning of your shift, always scan your patient list and assess your sickest patients first. We all know how easy it is to go and assess your walkie-talkies first and get them out of the way, but most code blues and rapid response activations and falls occur during shift change. You practice high reliability when you manage your patients this way and you reduce the risk of harm to the patient. A recent study showed up to 94% of unplanned ICU admissions showed some form of serious deviation in vital signs within 48 hours prior to transfer. In almost half of those cases, there were delays in recognizing and acting upon the abnormal vitals. Trends like this can lead to poor long-term survival rates, especially in the older population that we serve. Failure to rescue is the term used to define a failure to prevent an inpatient deterioration and death resulting from a complication of medical care or underlying illness. Missing the opportunity to rescue a patient from decline is a major safety issue and is highly sensitive to the quality of care that you provide. Understanding when and where these failures occur is essential to nurses to lessen any risk while the patient is under our care. Failure to rescue an unwell patient can be divided into 3 critical stages and represents several opportunities to improve patient safety. Failure to recognize the signs and symptoms of complications, failure to relay important information regarding those complications, and then failure to react in a timely and appropriate manner to a patient's deteriorating condition. The number one reason of failure to rescue is missed opportunities that involve monitoring the patient for signs and symptoms that could indicate deterioration. Best practice examples to improve monitoring and recognition are early warning score systems, electronic health record detection triggers, checklist, and proactive rounding by your rapid response team. At Baptist, we use the early warning score. The early warning score, also known as EWS, is a track and trigger tool used to detect potential deterioration and provide intervention bundles and escalation plan. It helps to identify deteriorating patients by quantifying abnormal vitals as well as other indicators of organ dysfunction. The composite score is used to classify the severity of patients' current hemodynamic situation. It is performed immediately after taking a full set of vital signs and is assessed frequently throughout each shift by nursing. It is not necessary to perform early warning score on comfort care DNR patients. In your packet, you will find the Vital Signs and Early Warning Score Monitoring for Acute Care Units form. This is the pathway that you will use to help guide you with frequency of vital signs and the assessment of the early warning score. Early warning scores of 2 or greater require interventions. After your interventions are complete, a reassessment of a full set of vital signs is required within 30 minutes. If your patient is continuously scoring a 2 or higher, then that patient will receive 6 sets of vitals Q shift. It is not unusual that a typical post-op patient could score a 2 or higher continuously throughout the shift. However, we need to continue to monitor them to make sure that we're doing all the interventions that we can do and that they are at least improving or staying the same, not getting worse. Please note the values in the parameters that score a 3. Those would be automatic calls to the provider in rapid response. On the back of that form, you will find the early warning score intervention bundles. These are meant to be documented as a bundle. So if you have a patient score a 3, we need to document the interventions as managing pain, fever, distress. We need to ensure that you've reviewed the past vital signs and lab results. You want to recheck the patient within 30 minutes after your interventions. Repeat a complete set of vital signs with early warning score within 30 minutes after interventions. And notify your charge nurse if there's no improvement in your vital sign or early warning score. And of course, if you score a 3 and a single parameter, stat notification to the primary provider team and consider a rapid response. If you have a score 4 to 5, that's when we move into a more critical state and we need to be assessing airway, breathing, circulation, level of alertness. You want to perform interventions, notify your charge nurse, get a second opinion, second set of eyes, notify primary provider team, allow them the opportunity to come to the bedside and evaluate the patient, and if we need to call rapid response, then do so now. A score 6 or higher, this is probably a medical emergency. We need to assess airway, breathing, circulation, level of alertness, and then work through our escalation plan. Notify the charge nurse, notify the primary team, visual assessment performed by a second nurse. Do what you can in your PRN arsenal. Get your rapid response nurse involved, get your respiratory therapist involved, and get this patient moved to a higher level of care. Also in your packet, clinical education has included an early warning score FAQs for you to review. And just to summarize, the early warning score is best practice to reduce failure to rescues if assessed accurately and with each set of vital sign assessment. All inpatients on the acute care units will have vital signs and early warning scores assessed and documented every 4 hours. You must have an explicit order from a provider if vital sign frequency is to be decreased. And you may defer if the patient is a DNR, comfort care only. Interventions and escalation plans must be documented for all early warning scores greater than or equal to 2 as a bundle. So that concludes this piece of patient care orientation. If you ever have any questions at all, please reach out to me. You can find me on Telmedic by searching Nova, Clinical, or Sepsis. And thank you for your time and welcome to Baptist.